Good morning, good afternoon, and good evening, everyone. This is Patricia from the International Hospital Federation. I hope you're all safe and well, and we're glad to have you here to join us live in this webinar. We are hosting this COVID-19 webinar and live Q&A series to share experiences, good practices, insights, and recommendations from our members and other organizations across the globe. The series has been created with healthcare providers for healthcare providers, including decision makers and those involved in managing COVID-19. We hope the lessons you take away from this webinar will help you in facing the crisis and beyond. So let's begin. I would now like to introduce our moderator, IHF CEO, Eric Durdenbeck. Eric?
Thank you very much, Patricia, and good morning, afternoon, or evening. Welcome everyone to our webinar that will take us today to Zambia. I'm sure that some of you are not familiar with Zambia, except perhaps for the famous Victoria Falls. So Zambia is an African landlocked country with around 17 million people that has been facing up-to-date limited impact of COVID. However, as it was discussed during our webinar hosted with World Bank last Friday, facing crises in low-resource countries is adding challenges to the challenge. This is what we are going to discuss today with the example of Zambia and how a private sector hospital has prepared to face the crisis, but more broadly, how efforts have been made to make health services more resilient, as well as prepared for the next normal or the new normal after this unique pandemic that we have all faced in most of the countries. Let me now introduce our speaker, Dr. Mohamed Al-Sahili. He's the Chief Executive Officer of SF Group of companies that is comprising the Medland Hospital, that is a member of the IHF community of members. This is the first hospital in Zambia that has been using cutting-edge techniques and latest equipment in the medical sector. Dr. Al-Sahili served before in a national bottling company as CEO until the company was acquired by a multinational group. So really a business experience outside from the healthcare industry, which can give a very interesting insight on the responding in a different way than the clinicians have the usual approach. He's a doctor by profession, as well as an entrepreneur, and he serves as the Vice President to the American Chamber of Commerce of Zambia. He's board member of the Corporate Council of Africa, also from the Olympic Youth Development Center. He's a representative at the African Business Roundtable, also member of Africa Health Federation. He presides the Care and Aim Network for Humanity in Zambia. His commitment towards women empowerment, waste management, wellness, and health constitutes a pillar of his vision. Dr. Al-Sahili, we welcome you, and please, the floor is yours.
Thank you, Eric, and good day to everyone. And I'm glad to have this session today with organized by IHF, because I do believe that also by sharing those experiences between developing and developed countries, we can increase our response to pandemics such as COVID-19. So just to start with few slides, I will share some information about Medland so that attendees can also have a better understanding of what is this private hospital in Zambia. So first, Medland Hospital is the Zambia's first private hospital offering specialized and comprehensive medical services of international standards in the heart of Lusaka, Zambia. Medland Hospital has been created on the basis of a comprehensive specialized hospital that provides discrete and individual quality care for both day and overnight stay in an elegant surrounding. At Medland, the patients they always do come first, and we are dedicated to providing an excellent standard of care to our patients in a friendly, safe, and comfortable environment. Our main focus is on delivering quality care and value for money. We play a key role in the health of our community by providing access to specialized medical services using the latest technology and empowering a team of highly trained and experienced healthcare professionals who practice cutting-edge medical and surgical techniques. We are the Zambia's first private hospital to have a fully fledged cardiac surgical unit equipped with the latest technology and expertise that can cater to a diverse array of cardiac conditions. Our main specialties include cardiac surgeries, interventional cardiology, surgical oncology, orthopedics and trauma, urology, ENT, general surgery, etc. But I want to also mention that among those services, we have the IVF, fertility, anti-aging medicine, and NICU, neonatology medicine that were still, let me say, rare services in the country. So on that, I will stop sharing those slides, and I will start with the presentation itself that will discuss the challenges that we face in developing countries, and I will take the experience of Medland Hospital in Zambia as an example. But before that, you may know that Zambia has a well-developed private and public health care system which provides specialized medical services such as diagnostic, curative. The private health sector in Zambia in particular has earned the reputation as providers of good quality healthcare. Government on its side has declared the healthcare system as a priority sector. When it comes to COVID-19 in the region, in Zambia, the global community is racing to slow down and eventually halt the spread of COVID-19, a pandemic that has claimed thousands of lives and sickened tens of thousands, if not millions of others. In Africa, the virus has spread to dozens of countries within weeks. Governments and health authorities across the continent are striving to limit widespread infections. Despite over hundreds of thousands confirmed cases in each country in Africa, the passage of COVID-19 through the African continent remains somewhat enigmatic. High numbers of deaths were expected in the region due to fragile health systems, lack of access to preventive measures, barriers to testing, and potentially vulnerable populations. In fact, for a disease with no vaccine, no clear course of treatment, it's even more important. Also because there is a lack of personal protective equipment, items like masks, gloves, hand hygiene becomes the fundamental measure to interrupt disease transmission. But the findings and the statistics were already alarming long time before that. I will take the example of a study done at the University of North California, where researchers examined environmental conditions in healthcare facilities in 78 low to middle income countries. The results published in 2018 paint a dismal picture. Only half of the nearly 130,000 healthcare facilities in the analysis had piped water. 39% did not have hand washing soap. 1/3 did not have satisfactory toilets. Nearly 3/4 did not have sterilization equipment. Only 2% of the facilities had the complete package of water, sanitation, hygiene, and proper waste disposal. But despite all what I have stated, according to WHO, Africa is the least affected region globally, with 1.5% of the world's reported COVID-19 cases, 0.1% of the world's death. Although comparisons are inaccurate, mortality rates have been lower compared with outbreaks of similar size elsewhere. Many hypotheses have been suggested for this paradox, including sensitivity of the virus to ambient temperature, Africa's comparatively young population, low rates of obesity, and familiarity with infectious disease outbreaks. Low levels of testing might be artificially lowering apparent infection rates as well. The situation in the continent is highly heterogeneous and progress varies considerably. So, having said that, we have to remember that there is no room for complacency. Medical capacity within Africa will be rapidly overwhelmed if containment fails, but vertical efforts concentrated on this outbreak threaten other hard-won gains. We immediately at Medland Hospital, on our own, and before the WHO announced this outbreak as a pandemic, started to see how best we can address this crisis. When the COVID-19 response committee gathering different departments' representatives was formed at Medland Hospital, there was no cases officially announced in Zambia. Ports of entry were still open for citizens and foreigners. The first step was to come up with an anticipated list of challenges, looking at the dynamics within the country and the region. We mainly focused on the human resources, the supply chain, the patient safety, and the public image. As a new player in the market since we have recently opened in August 2019, the task was not easy, especially that financial impact was to be projected and taken into consideration. Therefore, the response strategy was elaborated and different levels were set. At this moment, Medland Hospital is still at its level 2. When it comes to human resource angle, the key measure in tackling an outbreak like this one is the protection of our frontline staff. Without them, we couldn't respond to the pandemic. Thousands of them were falling ill across affected countries. So keeping them safe and free from infection was and still is a key. On the other hand, in an outbreak like this, we cannot only focus on hospital care. General practitioners and family doctors have a vital role to play as well. Before COVID-19, the health services worldwide were focused on individual care. Fortunately enough, being in Africa makes thinking about public health in an outbreak context much easier. Learning from other countries' experiences and noticing that the supply chain disruption was a common challenge, we have embarked on a facility assessment for emergency preparedness. Zambia is a landlocked country, as Eric has mentioned, and we rely in majority on imports. The closure of international borders, disruption of flights, supply chains, and export bans restrict the ability of African countries in general, and Zambia in particular, to procure personal protective equipment, diagnostics, essential food items, risking a disease spread and famine. Locally, the industry has responded with local solutions, such as establishing local supplies of masks, sanitizers, for example. We allocated the majority of our cash flow to order in advance large quantities of PPEs, consumables, laboratory reagents. That hasn't been an easy task, especially with the restrictions in different airports, so that we can reach on time and in full quantity ordered our purchased order. COVID-19 was a pandemic to live through, we knew that, and that will remain for many weeks with us, if not months. Patients will still seek medical services that are not related to the coronavirus outbreak. Therefore, the other main point to address was patients and staff safety. We have restricted, in some areas even banned, visitors at our facility. Cars were sprayed at the gates with chemicals to avoid transmission through car doors handlers. Checked at the new implemented triage area was a condition to access the facility. While there, everyone will have his temperature checked, is asked about the presence of flu-like symptoms, and the travel history. When level 2 response at Medland was reached, the travel history was deleted from the questionnaire. Although this may sound primary, but the segregation of people between red and green zone has helped in easing the process of entering a health facility. Tests for diagnosis are not available enough in the country, and asymptomatic persons are still considered a threat. However, WHO has recently announced that they are at lower risk of transmitting the virus compared with symptomatic patients. While addressing the previously mentioned points, we noticed that the image of health facilities was also disrupted. The lack of communication, the conspiracy theories among the general population, as well as the lack of awareness did not help. We decided to come on board with the COVID-19 awareness campaign unit and daily Facebook live coverages, all related to subjects that are directly or indirectly related to COVID-19 were discussed. New marketing strategy was put in place, an official common hashtag was released, and different partnerships with both private and public sectors on national, regional, and international levels were secured. Internally, trainings are ongoing on a regular basis on all levels. An inpatient section was redesigned and dedicated as an isolation department. Currently, as a private sector player, we are not allowed in Zambia to test or treat any patient for COVID-19. However, all suspected cases are treated in the red zone and admitted in the new isolation section. Ministry of Health does test all inpatients at Medland Hospital, regardless if a suspicion is there or not. We have also applied for a permit to test, as we do have at our own laboratory, a real-time PCR. This application is still pending. Bureaucracy remains main challenges. I shall stress also on the fact that the cooperation between Medland Hospital and the public authorities, mainly the Ministry of Health, was very successful, very fruitful, and it is leading to improvements on daily basis. Definitely there is still potential for disaster in Africa, especially as countries begin to ease the strictest lockdowns. The COVID-19 enforces global power structures. The rest of the world has a role in supporting, enabling an effective and safe response. But as much as Africa faces unique difficulties, it also has unique strength. There have been many national successes and an effective regional response. Future actions need to be Africa-led. The African Union, through the Office of Social Affairs Commissioner, has established a list of projects already in process or to be launched soon. Self-determination is key. I truly believe in times of crisis, every colleague should be contacted for input or advice. The strategy decision-making must remain in the hands of the C-suite players for a better accountable management. And the question remains what we will do post-COVID-19 with this key and magical word, the new normal. As Madeleine Hospital, we started setting up a strategy where we do know that the segregation between patients, not specifically in a manner of red-green zone, but this segregation will remain for a certain time, if not for months to come. Therefore, we are currently busy studying how we can implement a drive-through checkpoint for everyone that will be accessing Medland Hospital so that we can keep as much as we can people safe, especially that the numbers of asymptomatic patients is in raise. I will stop here. I have tried to list as much as I can and to cover what we have done, what we are going to do, and I will be ready to answer your questions or to discuss with you any item that you would like to debate.
Thank you very much for your presentation and highlighting what you have put in place in response to the major challenges. While we are waiting potential questions from the audience, there was one that was already sent out to us, which is the following. What are the common and special characters that led to the attainment of success in Zambia for lessons learned to other developing countries? What do you think that you have done really specifically in Zambia that other developing country could really take forward?
Well, I think the first thing that we have to mention is that we did not wait for anyone to ask the private sector to come and act. We did take that initiative on our own before even, as I said, this being declared as a pandemic. This helps a lot because we do all know the challenges that are in developing countries. We do all know that we have shortage in consumables, sometimes in medications. We do know that we have a limited number of healthcare givers that are available, and therefore we cannot risk putting at danger any of our not only team but also our colleagues in the other private sector players. Structures. So that was key for our response, I may say. The second item is that we do consider that despite the numbers, because as I mentioned also in the introduction, the numbers in Africa are not that high as they were expected to be, and therefore we don't take really those numbers into consideration, not because we don't respect them or that we don't trust them, but because we do know that we have a huge number of asymptomatic people, show the number of tests available be more. Therefore, what our let me say again key not notes, but key lesson that we have taken into consideration is that everyone is COVID-19 positive unless proven the opposite. So that was a standard that we have followed at Medland Hospital, and that has limited the spread of the virus within the facility itself, especially that our team is coming from different areas in Lusaka. Some of them are also coming from poor areas. For example, I will say the cleaners or the drivers. So that also was a major component in our response. The other thing is launching a dialogue, whether with our colleagues in private sector or with the public sector, to see how best we can address the crisis. And number four, I will say that being transparent with everything that we do, we always keep not only our patients, our public aware, but we also make our partners aware, whether from public, locally or regionally with the partners that we have, so that we can best address this crisis.
Yes, so you really emphasize the importance of being proactive and taking the decisions. In a private sector hospital, you are financed on fee-for-service, I guess. So
Yes.
how did you manage to cover the cost of preparedness, because preparedness is not paid for, and
Yes.
the cost of all the measures that you have put in place that could, in a nutshell, to put it in a nutshell, is reducing potentially the productivity or the capacity of the throughput of the organization. That means it's increasing your fixed cost for your potential activities. So how did you dealt with that? Because I think that that's something that all over the world, the private sector players have to find a way, because of course, as a private sector, if you don't balance your accounts, you run out of business.
Yes. So basically what we have done is, one, with the finance department, we have allocated all the unnecessary budgets for services that were, again, unnecessary at this time or at times of crisis. We have allocated all this budget to PPE purchase. And therefore, we empowered a little bit financially the procurement department. Having said that, what we have also done is that we went into looking at each kwacha, which is our local currency, that can be saved. So, for example, we, as a facility, we are a 4-story facility. We know that one of our challenges was an energy challenge, and therefore we do spend a lot of money on, for example, utilities. Therefore, what we have done is that we embarked into a better usage of utilities, and I think this will remain with us forever. which has reduced, again, our cost of operation on a daily basis. The other thing is that, for example, there are small decisions or initiatives that you can take internally that will really help. For example, the stationary spendings have drastically decreased because of the limitation of budget and of approvals to spend on that particular item. Again, what we have done is that the shifts among the team has also been studied in a way where we can still provide the service with the excellence of care without going into a huge bill of overtimes being paid, which won't help. At the same time, also there are some services that were available through the marketing team by stressing on the fact that people have to go for preventive medicine, better checkups, working with corporates, basically also sealing those corporate partnerships so that we can have a better screening of their employees' healthcare status, which will help us in our finance, but also it will help the corporate itself in knowing whom among their staff may be at a higher risk of contracting a disease or not. The same way applies to, for example, the enforcement of being a digital facility, which we all know does reduce a lot on the cost of operation on a daily basis. From a supply chain, I do know that, for example, we are spending more on providing PPEs to the team so that we can keep them safe. But I also do believe that a team that is disrupted because we did not take the measures that we need to keep everyone safe would have costed us much more.
So you, if I would summarize, the fact that you are a private player allowed you very quickly to take all these measures, which probably is not the case in the public sector because of the bureaucracy, because of the rules. So definitely in a situation of crisis, you demonstrate that here it's really a comparative advantage of the private sector in terms of, agility. And we have seen also in the previous webinars that agility has been really a key element in this current situation.
True. In fact, agility is a main point to tackle. And I have to say that we did not also, and basically agility does not allow you to fall into the panic mode. So, for example, we have seen a lot of facilities, whether in Zambia or outside, running to purchase goods that may be efficient or beneficial in other countries, but in our context, these things were not as much as essential. For example, everyone went, and I know a lot of my colleagues who went on purchasing some medications which were announced beneficial or having a role in saving lives, let me say. This is how it was marketed. But in fact, we did not embark into that. What we have done, at the contrary, we went into purchasing drugs and medications, consumables that are not related to COVID-19, because we do know that we are a landlocked country, and we do know that we still have diabetic patients, hypertensive patients, cardiac patients, cancer patients, and they need our support, and we cannot tell them when admitted or when seen by an outpatient doctor, we cannot tell them that we don't have this drug available. And that was a major also, I will not say marketing tool, but that was something that was felt by the general community. They have seen that as a facility, we have never mentioned the word that we are out of stock of this medication or that consumable. Even now, while we are talking and while the cardiac team is on a cardiac surgery, for example, the grafts, the valves, the consumables were made available since February, because we knew that it will come a time, even when other developed countries will go in uplifting travel bans and decisions like that, but they will still be in need, because many of the key industrial players, they went into producing, manufacturing PPE related products, and they just did not forget, but they did put on hold other products that are still in need, especially in our country, for example.
Yeah. So yeah, this is a supply chain, and we may perhaps come back to it later. Is really a critical element. I have a question related to the dynamic of the epidemic, especially in Africa, from a colleague in Ethiopia, mentioning that, to his knowledge, there are more female deaths in that has been recorded in African countries than male. And is it something that has been discussed between you and the public health people in your country? And wondering, you were talking about, a enigmatic spread of the COVID, how there is also this enigmatic differences, because it's rather the contrary in countries that have been more hidden by the COVID. It's more the male than the females.
Yes, so we did not have, honestly, a direct discussion about that with the public sector, but I sit on board of different institutions in the region and in the continent. One of them is the Africa Healthcare Federation, and that is a note that we have made, that female are, let me say, they are more reported. I don't want to say that they do contract the virus more than men. They are more reported for different reasons. One of them is because demographically we have more women than men. The other aspect is that the women, mainly in our region, are also more empowered by NGOs, and therefore they have better access to health education, to health awareness than men. And that is one of the reasons as well why we are seeing that number, because they are definitely tested more than men. And there is a category of women in the continent that is highly related to street vending. I'm sure you read about that. So street vendors are mainly women, and this group or this category is also targeted with mass testing, not only in Zambia but across the continent. Therefore, maybe women have better access or an increased access to test than men, and this is why we are seeing more women being reported than men.
Yeah, but the question was more about also the fatality numbers. I think there are more deaths that have been recorded, for example, in Ethiopia for women than men, but still, I mean, the figures are quite limited. So you can imagine that with so limited figures, there might be quite a lot of bias.
Exactly. We cannot really base our comments yet on the numbers that are reported because of the differences, because of the who is being tested. For instance, I am aware of some death that has occurred in the continent, and they are not reported as COVID-19 because they were more related according to the authorities in those countries, to diseases such as malaria or other epidemics. Therefore, the reporting is yet to be, I mean, we have to wait a little bit more on that. I don't think we can yet conclude on anything related mainly to mortalities, because, for example, if you take the case of Zambia, we have mainly deaths that are related to underlying morbidities and conditions such as cardiac or pulmonary conditions.
Yeah, so this is an important point, the reliability of the reporting and information system, which is, of course, more sensitive, of course, when the figures are very small also. Another questions about, you mentioned that you created your green and red zone, put it in red zone, those that you suspect to potentially be COVID positive, but organizing your hospital like that, did it mean that you had to restrict some patients to get services, or you were still able to provide all the services to all the patients for all the other pathologies that needed the services? So you may have to bear additional costs, for which you explain, how you made some saving in reorganizing your processes. But what about reduce the impact in reducing of the potential services to the patients?
Yes. So it has impacted the ancillary services somehow. I will give you an example. A patient, when a patient comes into the facility after being questioned at the triage area, is asked to go to the red zone or to the green zone. When seen at the red zone, then there is a doctor that will attend to the case. If a specialist is needed, then the specialist is called to come to the red zone, and before entering that red zone, the specialist will have to suit in proper PPE. And then the patient is being consulted and given the right appropriate instructions. Meanwhile, when at the red zone, also a request for a test of COVID-19 is made with the public authorities, and then the ZNPHI technicians will come in and will test the patient. If the patient is not to be admitted, then he is given the recommendations on how to be quarantined at home until the results are out of COVID-19 by the relevant public authority. If the patient is to be admitted, then he is admitted in a special zone that has been newly created, special isolation zone, and everything that is needed is being done, including surgeries, etc. Now, when it comes to ancillary services such as physiotherapy, for example, yes, this service is not available for not cleared patients, meaning that we will still wait for the results of the COVID-19 test before accepting that service to be provided. Again, during the provision of an ancillary service such as COVID-19, proper PPE as per the guidelines from CDC, from WHO are being followed so that we can also protect our physiotherapists. The chemotherapy, for example, or the dialysis services are provided in the red zone. So on that particular services, we don't have any problem. Obviously, we do know that this segregation is not definite. This segregation is not 100% secure, as we may have asymptomatic patients, and that is also why no one can enter the facility without a proper mask being worn for the safety of everyone.
But that's in the way you have organized yourself and the consequences in your capacity to deliver. What about the patient's fear coming into the hospital. You mentioned several times the marketing and the need to, demonstrate to the population what you are doing. Did you record a drop in your activities because people were fearful to come to the hospital because of the COVID?
Yes. So funny enough, when we decided to address the crisis, as I said very early, we thought that we are going to have a pickup in number of patients because people will see this as a positive decision forward. But we have seen a drop in the numbers, especially during the month of March. People were, one, afraid, and two, those who were coming to the facility, when they were seeing that we are separating patients, we have a red zone, green zone. So there was that thinking that we may have already admissions of COVID-19 and we are not just talking about it. This is one of the reasons why we have decided to go public and to talk and to say that we are playing our role as a private sector, but still the testing and diagnosis and admission of positive cases is held by the public authorities. Then in April, we have seen a tremendous pickup in numbers, as well as in May and now in June, because now people, they feel safe when they enter Medland Hospital. They know that we have taken all the measures to protect them and to protect our team. They know that the moment we will have any suspicion, we will do whatever is needed so that we do take care of the patient, of the suspected case, as well as the other residents at our facility. They have seen that we are not discriminating, we are not creating any stigma when it comes to suspects. At the contrary, we are treating them with high care because we do know that they also are worried and they want to know if they are positive when it comes to COVID-19 or not. So that drop, I think we went through it, and now people, even insurance companies, are more confident in sending their patients to Medland Hospital.
Yeah, that's very interesting because it demonstrates that it is somehow an investment to do.
Yes.
And that when it is done, you get the return on investment, if I say, through a enhanced trust by the population. You mentioned very much also the importance of having the leadership very active around the C-suite. Could you elaborate a little bit how first your leadership is organized and whether this period has made changes in the way the leadership was organized and relating with the rest of the staff and the facilities, within the facility, the clinicians?
Yes. So basically what we used to have in the past, we used to have our protocols, our SOPs. We have, I sit as a CEO. Recently, we are changing this into CVO. So we are canceling the CEO word. We have our hospital administrator, our medical director, and different committees that sit, meet, and they take some decisions. Sometimes these decisions, they need the approval of the board or myself. And in other cases, simpler decisions, they are just taken, and the flow of the work is as simple as it may sound. But during COVID-19, what has happened is that, yes, procurement is done through a procurement department and budgets are pre-approved. However, we have seen that in some cases we have urgent decisions to be made. For example, I will give a very simple, concrete example. The surfactant is a product that is highly needed in NICU. And if you look at the numbers of NICU beds in Zambia, you will see that it is very limited. When our procurement department was purchasing this product, the purchase was made as per the normal levels, respecting our threshold. What we have done, because we have directed everything now to the C-level for decision making, mainly to my office and the office of the hospital administrator, we have gone further and we have approved the purchase of extra amounts of this same product. And luckily we have done that because even the public sector in a certain period of time has run out of the product itself. So we were there to support. What does this mean? It means that during times of crisis, we may have, because we know what is the vision, we know what, and all the team knows what is the vision of the facility, but we also have access to information that may not be available for junior employees. And therefore, we have to take into consideration those information. We do know that, for example, borders will be locked or will be closed in few days because of an increase in numbers in truck drivers, for example. So we do know what products we are relying on through that border, and we take the initiative to have a supply respected. Then on the other hand, when it comes to marketing, it's very sensitive. At the end of the day, we are a healthcare facility, and we don't want to also fall in the or to look like we are promoting the hospital. Therefore, what we wanted to do is to take initiatives that maybe the business development department wouldn't have taken. So we were there to support them, to give them further instructions on how to partner with schools, with universities, with media players, how to organize a media webinar training so that also journalists can report better and more scientifically without relying on rumors. So what we have done is that the input of the C-level players has been not easy. I know it's a hard thing to do, but we have been micromanaging, let me say, more than ever before.
Yeah, but the fact that you are part of a larger group, that means the hospital is part of a larger group, did it help versus if you were just a standalone hospital?
Honestly, not, because I have to say also that Medland Hospital is helping the group somehow. We are a family business owned group, so decisions are easier. It's not like we sit on a board of 12 and more members. But the lessons that were taken by Medland were also easier to give to our sister companies, whether it is a sister company in the supply of consumables in healthcare or in real estate with residents, by addressing the crisis within the real estate properties or even in the hospitality sector. So it's I think it has helped us being part of that group, and unfortunately we did not take any advantage of being there, but I think the advantage was that we were able to share those lessons.
Yeah, thank you very much. I don't see any other questions. So before coming to the end of our webinar, let me share some takeaway messages before I give you the floor for final conclusions. So first of it is definitely the spread of COVID in the African region, as you said, has been quite enigmatic because there were very, very high concern on its potential impact because of the scarcity of resources and the weakness of the health sector. But it didn't happen up to date. But anyhow, this specific situation of weakness and scarcity has called for an early preparedness, and a preparedness that has to be driven by the frontline players, the service providers, without waiting for the health authorities to give instructions. The second very important element that you really develop is, and I understand that specifically in a landlocked country, but I think it's applicable also to all the other countries, is to give a very early focus on the supply chain, because, you know, if there is a breakdown of the supply chain, the whole thing falls apart. So it's recognizing, you know, that the supply chain is really the heart of the system, and that you have to put in place very early alternatives and solutions to make sure that you can maintain the consumables that you need, including by enhancing local solutions as much as possible to increase resilience. The third one is to put a lot of importance on the safety of your staff, safety of the patients, because same thing, it's about for the staff, the capacity to continue and operate. And of course, we all have, there is a social responsibility as an employer, but it is important. And the other thing is around, of course, the safety to the patients, because it's about the trust in regard to the hospital. The other lesson, which is also one that we heard in other parts of the world, is that when the private sector wants to come and collaborate and brings his capacities to a public health issue, often it still faces the problem of the bureaucracy. And this is not related to people, it's related to processes and rules that often prevents a quick mobilization, an effective mobilization of capacities to serve the population. And really, I think this is something that the authority should be looking at. And the example you gave about the laboratory and testing is really a great example around that. The last one is on the post-COVID. It is important because of the uncertainty that once you have put the organization that is securing the processes in terms of safety, that you continue to operate with that at least for a while and live with it. And the second thing that we heard also through the Q&A is that this crisis has also been an opportunity, because it has allowed you to do some kind of business process optimization and re-engineering that will have long-term benefits. Before giving you the floor and for the concluding remarks, I had two quick questions that came in the meantime, that I'll just put them for you and you'll do the conclusion. One is about restricting the patients from some services during the, did you have to restrict services to, no, this one was given. It's is rather the last one. It's on the collaborating, is your hospital supporting collaborating research in management area aligned to patient outcomes? Do you have tips for tension management?
Yes. So yeah, I saw the questions. First, let me say that we do support any collaboration on any and any partnership that may enhance our service and the service of the partner we are collaborating with. In regards with tips, I can respond to that privately. I mean, I can receive an email about this. The reason why I'm saying this, it's because we don't have it's like parenting. We don't have a one scenario. It really requires the taking into consideration all the aspects of the facility, all the aspects of the dynamics where the facility is, and therefore to see how best we can address that. When it comes to let me say tension management or the hospital management areas that are aligned with patient outcomes, we really have to also align that with what are we expecting from the facility to do, what are we expecting from the management, and where do we want to take that facility to. I have seen colleagues of mine who have decided to turn and to take their facilities to somewhere else, where, for example, now they are more into primary care, into rather than tertiary care, for example. I have seen managers who are falling into a panic mode for no reason, and this does not help because it will impact the whole team. I think the best way to do it is to really discuss this privately, but for me to say that we are open to any collaboration on that particular matter. And in general, and this is how I want to conclude, we are open to any partnership. You will see Medland is in partnership with a renowned university in the United States of America for the mental health. And it is also in partnership with another colleague of ours in the Middle East for example, for oncology. You will see that we are members at IHF because we do see an importance being a member at IHF, not only for networking, but also for learning from our colleagues and sharing some of our experiences such as doing today. I think the best thing that we have to do, especially as a player in a developing country, is not to stop dreaming. We have to knock on every door to see how we can best serve our community and how we can also best place ourselves among the developed countries players. I have seen results in even at Medland Hospital, medical results that can be shared, and the success stories that can be shared, even though we have been in the market only for 1 year. But that means that a well-structured team can do a lot. I think many have let me say, consultants, mainly financial consultants, have, when studying numbers, have seen or have concluded that Medland will be facing major crisis during the month of March. And this did not happen. It did not happen not because the consultants were not professional enough, but because also they did not take into consideration the measures that the management at Medland Hospital were going to take. So it's very important to tailor make a strategy that will suit not only the hospital owners or managers, but that will suit also the team working at the facility, and that will suit also the patients and the visitors that are coming across our services. That is my message. That is my goal, and that means that also the other party, the facing party in developed countries, they have to start welcoming those initiatives from players coming from developing countries such as Medland Hospital, because we can't always rely on exporting our goods, our products. I think now it's time to think or to implement local production, local supply, and also local delivery of medical services. And it is time to start talking about intracontinental medical travel within Africa, the same way we talk about that intra-regional medical travel and within the same country, because we do know that we have countries with very large areas, and now we are talking about intra-provincial medical travel. So yes, medical tourism is a key word that was sold to developing countries. I don't think it applies on us. I think we are still at the level of medical travel, and that will start to happen because of COVID-19 and the lessons that we have taken.
Thank you very much. And with this concluding remark, insisting on the importance of collaboration, Patricia, you may take the floor for the last comments related to the webinar. Thank you.
Thank you very much, Eric, and Dr. Sahili. Thank you so much for that very informative discussion. We still have a couple of webinars in the next few days. We hope you can join them too. If you would like to register, just go to www.ihf-fih.org/webinars. So we hope you can join us there too. In the meantime, please stay safe and healthy. Together we will overcome this crisis. Thank you again for joining us today. And Dr. Sahili, thank you so much for your contribution in this webinar. Goodbye, everyone.
Goodbye, everyone.
Bye. Thank you.